Good afternoon, everyone. I'm Julie Kalkbrenner with Lurie Physician Services, and I'm a physician liaison for the West and Northwest suburbs. Thank you for joining us this afternoon. We're happy to bring you a talk by Dr. Lisa Akhtar regarding common HSV questions for mom and baby. And with that said, I would like to take this opportunity to introduce Dr. Akhtar, but before I do, I also wanted to let you know that we will have some time for some questions at the end of Dr. Akhtar's presentation. So if you'd like, you can type your questions in the question box on the right-hand side of your screen, or you can just raise your hand and we can open up the talk to you. So thank you very much, and I'd like to introduce you to Dr. Akhtar.
Okay. So hopefully everyone can see my screen and hear me now. Let's see. Okay. All right. Well, thank you so much for the opportunity to present today. I wanted to take everyone through some common HSV questions for mom and baby. So I know this can be a really challenging topic because on one hand, it's such a rare disease. And on the other hand, when it does occur, it's so devastating. So that can make balancing your level of concern just really difficult. Let's see. So I recognize that most of the people on this webinar are probably outpatient pediatricians. So I really wanted to focus today on providing you with the information that you'll need to appropriately suspect, recognize, and refer kids with neonatal HSV disease to the emergency department. But I also want to provide you with the resources that are necessary to manage these children and families after hospital discharge. I know though that some of the folks on this call are probably general pediatricians who are hospitalists. So I'm also going to briefly talk about inpatient treatment and management of neonatal HSV disease. So here's sort of how I'm going to walk through things. So I'm going to give a little bit of an introduction of neonatal HSV disease so that we're all starting from the same point. I want to let you know and go through a case about when you should be concerned about neonatal HSV disease. I want to walk briefly through treatment in the inpatient setting, but also spend a little bit of time talking about how to manage these patients and families in the outpatient setting. And I also wanted to go through counseling parents in this post-discharge period when they really start to have a lot of questions about why this happened, why we need these treatments. And one big thing that always comes up in my experience is, what do we do when we're ready to have another baby and what are the risks involved? And then I'll just finish up at the end walking you through how Lurie infectious diseases can help. All right, so just a brief introduction to start with. Each year worldwide, about 14,000 neonates are infected with HSV. Infection typically happens due to maternal genital shedding of HSV1 or HSV2 at the time of birth. So when the baby is actually passing through the birth canal. That accounts for about 85% of babies who are infected. It is possible to become infected in other scenarios. So about 10% of babies we think are infected postnatally, most commonly because another caregiver makes oral contact with the baby in the setting of either a cold sore type lesion or just asymptomatic oral shedding. And another 5% of babies become infected in utero, actually. So this presents a little bit differently as more of a congenital infection. And those babies can actually be born with both active skin lesions and scarring from previous skin lesions that occurred in utero, as well as a number of other congenital type lesions, so abnormalities of the brain, etc. The greatest risk to the baby is when the mom has a primary infection toward the end of pregnancy. So we all know that moms can have genital infection that is either primary or first onset infection. But once you have HSV, you own it for life. So moms can continue to have recurrent infections lifelong. But the risk is really much greater during primary infection. So the landmark study that was done in 2003 by Zane Brown and colleagues showed that when a mother has a new onset primary infection toward the end of pregnancy, the baby is at nearly a 60% risk of transmission, whereas if the mother is having a recurrence of infection, the baby is only about 2% risk of infection. And that is due to multiple factors, but most likely because in the setting of recurrent infection, the mom can pass antibodies to the baby toward the end of pregnancy to protect that baby somewhat, and also just the levels of genital viral infection at the time of primary infection are thought to be much higher. This is an important point though, and I'm going to say it several times during my presentation today. Most mothers are unaware that they are infected. Whether they have primary infection or recurrent infection, the most typical presentation of genital infection in the mom is no symptoms at all. So oftentimes, the first time that the mother is finding out that she has genital HSV infection is at the time that her baby is diagnosed with a pretty serious illness. So once babies become infected with HSV disease as a neonate, they can take really different clinical courses. So about 45% or about half of babies are affected only with non-invasive skin, eye, and mouth disease, whereas the other half of babies are affected by some form of invasive disease. So about 30% are affected by central nervous system or CNS disease, and another 25% are affected by disseminated disease where the virus is spread throughout the body. Babies affected by invasive forms of disease have much higher rates of mortality. So even with appropriate treatment, babies with disseminated disease will die about 30% of the time. And babies affected by CNS disease, although with appropriate treatment, mortality is much less likely, they do go on to have pretty high rates of neurologic impairment long term. It's important to state though that even though these statistics are relatively grim, the fact that we're at this point where so many babies are surviving disease is a real testament to all the work that has been done by the NIAID Collaborative Antiviral Study Group and the just really painstaking trials that have been done over the course of really 4 decades to optimize IVA cyclovir and then oral acyclovir therapy to get us to the point that so many babies are actually surviving infection. So although this is a relatively rare disease, one of the reasons that we're talking about it today is because we are expecting, and many experts are expecting, that neonatal HSV disease in this country will actually rise over the coming years. So as I said previously, currently about 1 in 3,200 births in the US is affected by neonatal HSV disease. But overall in this country, the incidence of genital infection is rising. And the reason for that is a little bit complicated, but in general, HSV2 genital infection is staying about the same, but genital HSV1 infection, particularly new onset infection in young adolescents and young women, is really rising. And that is resulting in, number one, because incident HSV infections are rising and incident infections are at a greater risk of transmission to the baby. Neonatal HSV infection in relatively recent studies has started to shift from being predominantly disease of HSV2 infection to disease of HSV1 infection. And then because the overall burden of genital infection is rising in this country, that's translating into an overall increase in neonatal HSV disease cases. And the reason for the rise in genital HSV1 infection, particularly in adolescents and young adults, is really interesting, and I just wanted to talk about it briefly today. So this was really highlighted by the studies that are being done every several years through the NHANES data. So in this paper that was published by Heather Bradley in 2014, you can see here that in this youngest age group of persons aged 14 to 19, in the most recent time period that was published in this paper, 2005 to 2010, the incidence or the prevalence, the seroprevalence of HSV1 infection decreased substantially. So that means that in the United States, in young people, in the setting of better hygiene and overall care, young people are becoming infected with HSV-1, typically oral HSV-1, less frequently in early life. So that sounds good, but what it means is that young people are reaching the age of sexual debut without having any antibody protection to HSV-1. And that fact, combined with some shifts in sexual practices that have occurred really since the onset of the AIDS epidemic, where people have in some cases shifted to oral sexual practices as a means of achieving safer sexual practices, in the setting of decreased exposure to HSV-1 before sexual debut. This kind of created the perfect storm for a real rise in new onset genital HSV-1 infections, which is now being translated into a rise in neonatal HSV-1 infections. This primary work was done by Heather Bradley, which I have at the bottom right corner of this slide, but it was also, that argument was sort of nicely summarized in an editorial that was written by David Kimberlin in that same article of the Journal of Infectious Diseases. I just wanted to sort of state briefly that because of all these factors that we're talking about, neonatal HSV infection really looks different in different countries. So, for instance, in the United States, we talked about the fact that the prevalence of both HSV-1 and HSV-2 are quite low, which means that most infections are incident infections, and because those are the incident infections are more likely to be HSV-1, neonatal HSV infection is really being driven by HSV-1. However, in other regions of the world where practices are different, rates of prevalence are different, such as the number of countries in the African continent, prevalence of both HSV-1 at an early age is much higher and HSV-2. So that leads to a situation where more infections are actually, a greater proportion of infections are caused by prevalent infections than in the United States and in the Americas. And because HSV-2 is so prominent in many African countries, neonatal HSV infection is still largely dominated by HSV-2. So just kind of an interesting example of how these different factors, incident prevalent infections and HSV-1 versus HSV-2 come into play. Okay, so getting back to our outpatient practice, when should you be concerned about neonatal HSV infection? So I just wanted to quickly go through one case that might happen in the outpatient setting so that we can really all kind of put ourselves in the moment. So in your practice, you have a 22-day-old ex-full-term neonate who comes into your outpatient center for care with fever and irritability. So this baby was fine until about 1 day prior to presentation when they became more irritable, and they're now inconsolable. And today they developed fever. So this mom had prenatal care. She had infectious labs at the beginning and in the 3rd trimester of pregnancy, including HIV, and all of these labs were unremarkable. GBS was negative, and she has no history of oral or genital lesions. This baby was born by spontaneous vaginal delivery without any complication, but because of some monitoring abnormalities, a scalp electrode was placed to assist with monitoring. The baby has been well since the time of discharge. The baby went home at 48 hours, and until the current presentation has been fine. On your exam, the baby is febrile and tachycardic. Their blood pressure is normal. They are quite irritable, but they have no skin lesions, and their neurologic exam is non-focal. So what are the different presentations of neonatal HSV disease? So skin disease or SEM disease typically presents within the first 1 to 2 weeks of life, so relatively early on. And these babies have skin lesions, as the name suggests, in about 80 to 85% of cases. Some babies will not have lesions, but will have virus present on the skin, and other babies will only have eye involvement, but won't have skin lesions present. But these babies can, in some circumstances, be otherwise quite well appearing and without fever. If you see a lesion, you should still be concerned and refer the baby to the emergency department. CNS disease presents later for reasons that we don't completely understand, but typically within weeks 2 to 3 of life, and even in some circumstances a little bit later. Only about 60% of these babies do have skin lesions, so it's really important to keep a high level of concern, even in the absence of skin lesions. But these babies often have fever and irritability, and you should have a very high level of suspicion in the setting of anything that sounds like seizure. And just remember that seizure manifestations in these very young babies can be quite subtle. Disseminated disease presents earlier on, closer to the presentation of SCM disease, about 1 to 2 weeks of life. Again, only about 60% of these babies will have lesions. So in the setting of fever and anything that looks like a sepsis syndrome, respiratory distress, or any concern for liver dysfunction or coagulopathy, those are common end organ sites of neonatal HSV disease. So just some additional risk factors to keep in mind, but again, these should be used to increase your suspicion, but not really to decrease your suspicion for disease, because these things are not always present. So for mom, if she is known to have either a primary genital HSV-like disease, or if she's known to have recurrent infection, that would raise your suspicion. But again, most moms don't know. The most typical presentation of genital HSV disease is the lack of symptoms. Vaginal delivery would increase the risk over a C-section, particularly if the C-section was performed before rupture of membranes, because once rupture happens, you can have ascending disease. And in the Brown study, they defined that younger maternal age was also associated with an increased risk of disease. In terms of baby prematurity, particularly for CNS disease, raises the concern or raises the likelihood of transmission. And then any intervention where the skin is broken during the time of delivery in the setting of contact with the birth canal, such as a scalp electrode, can increase the likelihood of disease. So going back to our baby, you refer this baby into the Lurie emergency department. Their exam is as was previously described, only now they're having intermittent desaturations. They do a full workup in the setting of this baby with a fever who is irritable and having some abnormalities. The CBC looks okay. The CMP, including LFTs, is normal. Coags are normal. They collect blood and urine cultures. The UA is normal. The CSF does show a lymphocyte and monocyte predominant pleocytosis that's relatively moderate, 155 white blood cells. There are no red blood cells, and glucose and protein are normal. The CSF gram stain shows white blood cells but no organisms, and a culture and a meningitis encephalitis panel are pending. Because of increased concern for HSV in this baby, they send whole blood, CSF, and surface swabs for HSV PCR. They get a chest x-ray in the setting of these desaturations, which is unremarkable, and start the baby on empiric therapy, including acyclovir. So how do we diagnose this baby, and what are some additional considerations? So in the setting of SCM disease, the skin lesions or the surface swabs will test positive for HSV. You also want to evaluate for other evidence of eye disease in these babies. So having ophthalmology come, we'll talk about this in a second, but having ophthalmology come to evaluate the baby at some point is really important. But if there are any additional concerns for eye disease, it would be important to have them come right away. Blood PCR may be positive for HSV in this baby, but to categorize them as SCM disease, you would not have any CNS involvement or other end organ damage. In the setting of CNS disease, the CSF HSV PCR is positive. And just to mention, we do consider a dedicated HSV PCR to be a little bit more sensitive than the meningitis encephalitis panel. So if you do have high concern for HSV, I would recommend sending a specific dedicated HSV PCR from the CSF in addition to the meningitis encephalitis panel. These babies will oftentimes have a lymphocyte predominant pleocytosis in the CSF. It is something that we associate with HSV, that you may have red blood cells or xanthochromia in the CSF as well, but just keep in mind that this is not necessary for a diagnosis or to have raised concern, and it's not even really likely. So this thought comes from the fact that HSV is a very destructive hemorrhagic virus, and later in the disease course, you can have destruction of brain tissue leading to the release of red blood cells and the the presence of red blood cell breakdown products in the CSF. But ideally, in most circumstances, we're catching these infections very early when you don't have that type of destruction. So please don't use that as a reason to decrease your suspicion in these cases. Blood PCR may also be positive and skin lesions may be present. But for a diagnosis of disseminated disease, you really need both the presence of an HSV positive PCR from the blood and evidence of end organ disease. So an elevation in the LFTs or some type of coagulopathy or pneumonitis. These babies may have skin lesions, and in about 2/3 of cases, they often have CNS involvement, but not always. So back to our baby, there was evidence of a lymphocyte predominant pleocytosis, and the meningitis encephalitis panel, as well as the dedicated CSF PCR, were both positive for HSV1. The blood was also positive in this baby, but surface swabs were negative. They looked appropriately for evidence of end organ involvement or disseminated disease in the setting of a positive blood PCR. But this baby had an unremarkable chest x-ray and didn't have any evidence of liver abnormalities. This baby, I mentioned before, did have intermittent desaturations at the point that they presented to the emergency department, so I just wanted to point this out. This baby actually had an EEG and it was found that these intermittent desaturations were subtle manifestations of seizure activity that was happening for this baby. So this baby was diagnosed with CNS neonatal HSV disease. All right, so they go to the inpatient setting and they receive treatment. So all babies with all categories of disease are going to receive high dose IV acyclovir at 60 milligrams per kilogram per day, divided every 8 hours. Babies with non-invasive skin, eye, and mouth disease will get 14 days of therapy, and babies with invasive forms of disease, either disseminated or CNS disease, will get 21 days of therapy. All babies should have an eye exam to rule out eye disease, because that would require additional treatment by ophthalmology, and should get neuroimaging. So really in this case, just to establish baseline neuroanatomy for future reference. If the baby does have CNS disease, they will need an LP again toward the end of therapy to confirm clearance. It is not extremely common for a baby to not clear or still have a CSF that is PCR positive at the end of 21 days of therapy, but it does occur more likely in the setting of HSV2 disease than HSV1. And I already pointed this out, but I'll just mention again that the use of this high dose IV acyclovir therapy, number one, represents really decades of work in terms of optimizing therapy, but has really resulted in a significantly decreased mortality. So taking mortality of CNS disease from close to 50% down to about 4 or 5%, and taking the mortality of disseminated disease from 85% down to 30%. In the interest of time, I'm going to actually just skip over this relatively rare presentation, but I will just highlight that in the setting that an asymptomatic neonate is born to a mother with a maternal genital lesion, there is specific guidance that's present in the Red Book, and also this article that was written by David Kimberlin in Pediatrics in 2013 that basically tries to categorize the risk of transmission to the baby. So identifying early whether this is a primary lesion for a mom or an evidence of recurrent illness through serology testing on the mom, and then stratifying the baby appropriately. But in the most high risk situations, actually treating the baby empirically for 10 days. But again, we can talk about that more if you have questions. All right, so how are you going to handle this baby post-discharge in the outpatient setting? So all babies are going to get 6 months of oral acyclovir therapy at 300 milligrams per meter square per dose, 3 times a day. The important things to follow in these babies, so the most likely side effect of this medication is neutropenia. So you're going to want to get a CBC with differential at 2 weeks after starting therapy, 4 weeks after starting therapy, and as long as those are okay, just following monthly to evaluate for neutropenia. You want to adjust the dose for growth monthly, and that requires getting a weight and a length because this medication is dosed by body surface area. And then just ensuring that there are no missed doses, the parents aren't having trouble getting the medications. Anecdotally, babies kind of love this medication, and parents typically don't have any trouble getting their babies to take it. If you're in the Lurie system, Epic actually calculates the dose based on body surface area really nicely. If for some reason you find yourself outside of that scenario, I really like MedCalc, which is pictured here. So basically you plug in the weight and height of the baby, and once you press calculate, you'll just need to change the body surface area equation. I think it defaults to the DeVos equation, but I like the Mollister equation a little bit better. So you just change it to the Mollister equation, and it'll calculate the body surface area for you so that you can calculate the dose. In addition, I really like these babies to follow up with infectious disease once, either at the initial visit or pretty early on, so that we can answer questions, and then again at the end of the 6-month period. If the baby has CNS involvement, you'll want to establish care with early intervention and then also have follow-up with neurology. I would have a really low threshold for engaging other babies who have either disseminated disease without CNS involvement or even just SEM disease. I would also have a really low threshold for engaging them with early intervention as well. And if they have eye disease, you want to make sure that they continue to follow up with ophthalmology. Any outbreak within the first 6 months generally requires a complete workup in the emergency department. At the end of 6 months, I like to assess the risks and benefits of continuing suppressive therapy longer. Just to be clear, there is no known benefit for neurologic development past 6 months of therapy, but it just hasn't been studied. So oftentimes I will take into consideration the category of disease and what is the risk to the baby of repeated clinical or subclinical recurrences. So do we know that there's disease in the brain? Do we know that there's disease in the eye? Can the baby tolerate having any subclinical recurrences? HSV2 tends to be more likely to be invasive and to cause bad outcomes than HSV1, so I will often consider that as well. And then, has the acyclovir been tolerated? If you've had to stop therapy multiple times due to neutropenia, maybe it's in the best interest of the baby to just go ahead and stop. And then once they're off of suppressive therapy, you can treat recurrences with episodic therapy, and we can always reevaluate the need to resume suppressive therapy. All right, so when you're talking with parents about why we need to continue for 6 months with oral acyclovir therapy, it has been shown to improve cognitive outcomes at 12 months in babies who have CNS disease. So it's presumed, as I said, that this is due to subclinical reactivation and that stopping this leads to better outcomes. It's also been shown in babies just with SEM disease to decrease lesion recurrence. Like I said, in the first 6 months, typically they would need to go into the hospital for a complete workup if they did have a recurrence. So decreasing this really decreases medical intervention, family stress, and healthcare costs. I'll go quickly through this in the interest of time, but parents want to know, is their baby going to develop normally? And the answer is we don't totally know. So babies with SEM disease are very unlikely to have poor neurologic outcomes or any decrease in their neurologic outcomes. Babies with CNS disease are much more likely to. In the studies that were done by David Kimberlin in 2011, neurologic impairment was brought down to about 30% under study conditions when babies were given oral acyclovir prophylaxis for 6 months. But again, on a baby-by-baby basis, it's just not entirely clear, and that's why we get them hooked up with early intervention early and try to recognize any learning differences early so that we can adjust around them. And the last question that parents often have is, what happens if we want to have another baby? And the key to this question is recurrent infection is much less likely to cause problems or transmission to the baby than primary disease. And the other good thing is, once you know you have infection, there are other measures that you can take to decrease the likelihood of recurrent activation around the time of birth. So these measures are really focused on decreasing interaction between the neonate and the virus within the birth canal So moms will get acyclovir or valacyclovir prophylaxis starting at 36 weeks to suppress any lesion recurrence. And if there is lesion recurrence around the time of delivery, C-section is recommended to make sure that there's no contact with between baby and an active lesion. So how can we help? We always want to know about these babies. Inpatient to help answer any family questions. I am happy to be available to help in any way that we can with outpatient care. So ideally, I like to see these babies at least once in the beginning and then at the end to discuss the duration of prophylaxis. But I am happy to do anything that helps. So sometimes I follow these babies monthly if the family feels more comfortable or the PCP feels more comfortable. I can also they can also get all the CBC and the measurements done at your office, and I can follow them by telemedicine monthly if they feel more comfortable. Or I often assist PCPs just via email to double check any abnormalities in the CBC or to assist with calculating the correct dose of medication. So I'm happy to do anything that will assist you. And I'll just give a very quick plug. I know we are now short on time, but I'll give a very quick plug for research. So I love to know about these babies. My research interest is trying to understand how viral genetic variations in HSV contribute to different outcomes. So are there viral genetic variations that lead to one baby getting SEM disease and another baby getting CNS disease? And we use a number of basic science approaches to do that. But this is a rare disease, and so getting more viruses in more clinical situations is always very helpful to me. So I have an active IRB that covers the collection of the isolates. And so if you are able to make me aware of any cases, that would be fantastic. So this is my contact information, and I would be happy to take any questions that we have time for.
Thank you, Dr. Akhtar. That was excellent information. You shared a lot of little pearls in there. I actually did have a couple questions, but you answered them with your slides. Just to recap, you had mentioned, are you doing prenatal counseling then? Would you say that you are doing that for families?
So I don't formally do prenatal counseling, but it just sort of happens in the context of taking care of patients that I'm already sort of caring for in the context of active neonatal HSV disease. But I'd be happy to discuss that with any families that would need it.
Okay, and then lastly, are you, for patients that may live further out from the city, are you able to do some of these consults through your telehealth program?
Yes, it becomes a little bit easier if that can be done in conjunction with the PCP, just because we do, it's easy to send someone for labs as an outpatient. It's a little bit harder to get an accurate weight and length measurement, which we need for the dose adjustments. But telemedicine works really nicely in communication with the PCP who's seeing them on a monthly basis.
Wonderful. Wonderful. Well, thank you so much. If there aren't any other questions, I think we can start wrapping this session up. Again, thank you very much for the excellent information. This session has been recorded, so we will be sharing this out later by the end of the week. And one other thing is that we have 2 other programs this afternoon. We'll be talking about HIV and Kawasaki disease. So